the periphery at the individual level also, we can modify our screening of diabetic retinopathy methods and implement and do even with the practice of one or two doctors, with other group practice or even single-handed also we can do it. This is the global scenario of the diabetic epidemic. Unless otherwise we tackle this one, we will be in the near future. Second cause of major cause of blindness will be in India will be going to take up the diabetes. Already the major cause of blindness in America is the diabetes, retinopathy. Already India have 20% of the diabetic patients have diabetic retinopathy. Unless otherwise we treat them, they go blind. 20 to 40% of diabetic patients in India right now, it varies from 20 to 40%. In some institutes it is 25%, some institutes 30%. Average is 28 to 30% all over country. Of the diabetic patients have diabetic retinopathy. Out of them, 5 to 10% have diabetic retinopathy. Visual threatening is the diabetic macular edema, high risk for diabetic retinopathy. What are the challenges for diabetic retinopathy program? Inadequate facilities for diagnosis, investigation management, asymptomatic till visual compromise occurs, late presentation. This scenario of diabetic retinopathy in India is poor metabolic control, rural population, illiteracy, treatment, expensive, vascular complications, and poor referral awareness and counseling by physicians, especially diabetologists. What are the objectives? To prevent development of retinopathy, to prevent progression of retinopathy, to prevent vision impairment. Screening protocol is like this. These are the challenges. Our low-cost telescreen model is like this. All you need is a low-cost diabetic retinopathy screening. Nowadays in the market, lot of non-mediatic fundus cameras are coming, available with the range of 3 to 5 lakhs. Varies from nowadays still new models are coming up. And a laptop with good, of course nowadays everybody is using 3G, 4G, mobile phones, laptops, internets and everything. And a small mobile van like Maruti Omni van, and retina specialist sitting in the base hospital, and we can easily train our technicians to take fundus pictures of non-mediatic people of the fundus of the patient. This is our retinopathy project started way back. This simple van. This is the fundus camera which I use. Very simple and user-friendly, user-friendly. Technician can use it. And this is what I was telling you. Suppose if you go to periphery and ask the patient to tell them they got retinopathy, they don't believe us. They want evidence-based. So in the periphery itself, we take the printout of the retina, we give this chart, this paper to the patient and show them, point to the pointer. So these are the areas of retinopathy. We take the printout of this film, patient name and everything. On the site itself, in the periphery itself, the rural areas in the diabetic camp, we take the printout, give to the patient and explain to them. Then they believe us and they come to the hospital treatment. So this way we are one step ahead of others, giving the printout to the patients. And this way you can take ordinary bond paper and give to the patient. Once they come to the hospital, we can take on the glossy paper. So this our model is, we take the role model from Arvind Eye Hospital, which my teachers are there. They are my teachers. I did my retina fellowship in the Arvind model. Internet and 3G. At the base hospital, retina specialist sits in the retina clinic. This is how they take the pictures here. Laptop and internet, 2G and mobile things. And Arvind is using previously this model, ISRO vans. Nowadays there is no need for such high-tech ISRO vans. As you are aware, technology is improving day by day. 1G, 2G, 3G, 4G. So everything is coming. Previously when we were there, we used to take the CDs for the conferences. Now it's only simple pen drive. Take the fundus pictures like this, printouts like this, and here we attach the mobile internet. From here, patient is sitting and after taking the fundus picture, we transfer the image to the base hospital within 2-3 minutes by email. Retina specialist is sitting in the clinic and our assistant patient retina specialist will speak to the patient on his mobile. He is showing the fundus picture here and the patient is saying, seeing is more believing. So in that way, laptop, mobile internet, fundus camera, technician sitting in the hospital, retina specialist sitting in the base hospital, talk to the patient, show them their retinopathy, come to the hospital. So this is more one step ahead of convincing the patients. Well, these are the challenges. Unless we work in close liaison with diabetologists and physicians, we cannot single-handedly ophthalmologists cannot control retinopathy. So education is the prime importance. Educating the paramedical staff, NGOs, creation of self-help groups, etc. There are the awareness programs. But we need to have nowadays, as Dr. Narendra said, we are keeping them nowadays in the major metropolitan cities. All the diabetologists are having fundus cameras in their hospitals, and that includes the complete total package of diabetic checkup, diabetic retinopathy checkup, diabetic neuropathy checkup. And nowadays, all the corporate diabetic hospitals they are having everything, including fundus camera. They charge them, and they refer the patient and transfer the image to our eye hospital. We advise them. It's just like a close correlation. That means for initial screening of retinopathy, patient need not come to the hospital without wasting his time and retina specialist time. Technician can do the job. Particular hour, suppose say our people will go to the periphery of 50 kilometers in a specific time of 1 hour. Morning 10 to 2 they screen all the patients. From 2 to 3 they transmit the image to the base hospital. Our retina specialist spends 1 hour in the retina, in the laptop, something like this. So the retina specialist need not waste his time going to the periphery. And initially he is going, but now he is not going. Only technicians are well trained to transmit the images. This is the basic, simple way of doing things, seeing the things, advising the patients. Thank you.